Hello, Dr. Maunil. Thank you for
Hi,
joining us.
hi, Mr. Sandesh. Hi, good evening.
All right, we'll just get started here. Welcome to everyone joining us today. Welcome to the India's third Metabolic Health Conference. I'm a member of DLife.in, India's first and the only award-winning low carb platform. DLife was founded by Anup Singh in 2014, a silver medalist from IIT Roorkee and the recipient of Icons of India Award. Anup is the pioneer of the low carb movement in India with this path breaking protocol of 100 grams carbs per day max given by him in 2012 that made not only LCHF, low carb healthy fat, but even type 2 diabetes remission possible for Indian vegetarians. In 2021, DLife launched its diploma course, which is the only course approved under NSTC partner, the Government of India, in this segment, and the only course with the global biggest 144 hours CPD hours credit. Anup, along with Shashikant Iyengar, are the co-organizers of this Metabolic Health Conference. I'm Sandesh Bhatt. I will be the host for this discussion, and with me is Dr. Neha Sadhwani, the co-host for our discussion. Dr. Neha, would you like to introduce yourself? Dr. Neha, you're on
Neha,
mute. You'll have to unmute.
I'm sorry. Hi, thank
Oh,
you,
sorry.
Sandesh. I'm Dr. Neha Sadhwani, a practicing dentist. I have been a beneficiary of low carb lifestyle and DLife.in. Using low carb, I have been able to overcome my own weight challenges and lost about 15 kgs. I also want to call out to all the listeners that I have no financial affiliation with DLife.in, and my presence here is purely out of my own passion and giving a bit back to the community. It is my pleasure and honor to invite Dr. Maunil Patel here with us today. Dr. Maunil is a consultant anesthetist working in high-stakes environment of emergency medicine. He has a unique first-hand understanding of critical impact that chronic diseases have on individuals. He is also a senior resident at emergency medicine at Sardar Vallabhbhai Patel Hospital. Dr. Maunil is also D-Life member and certified metabolic health practitioner. His background in anesthesiology and emergency response complements his passion for metabolic health coaching as he is driven to help others achieve lasting health through nutrition, fitness, and lifestyle modification. By promoting these preventive measures, he aims to reduce the frequency and severity of these preventable emergencies. Hi, Dr. Monil.
Hello, good evening, everyone. As Dr. Neha introduced me, I'm a doctor working in emergency medicine department. So I see firsthand how insulin resistance play a critical role that is often overlooked in our acute medical crisis, whether it's diabetic ketoacidosis, gestational diabetes, the cardiovascular emergencies. We tend to overlook this term. But the opportunity to bring this discussion to a global stage is very invaluable, and it speaks volumes about DLife's commitment to evidence-based patient-centered care. And DLife.in is more than just a community; it's a movement that empowers doctors, healthcare professionals, and individuals to challenge these outdated paradigms and embrace metabolic health as the foundation of the disease prevention and management.
So I'd like to ask you this thing. Would you like to explain us the role of insulin resistance in acute and emergency department?
Yes. Like I said, it's an honor to be here today to discuss this topic that is very often overlooked in our acute care. Most of us recognize high blood pressure, that is hypertension and uncontrolled diabetes, as a major risk factor for strokes, heart disease, and sepsis. But what's often overlooked is the insulin resistance part. So basically, I will discuss that. It's been discussed already, but what is insulin resistance? Insulin resistance occurs when our cells in our muscles, fat, and liver don't respond well to insulin and can't easily take up the glucose from your blood. As a result, our pancreas makes more insulin to help glucose enter the cell. As long as your pancreas can make enough insulin to overcome your cells' weak response to insulin, your blood glucose levels will stay in the healthy range. But what happens in insulin resistance? Let's understand the mechanism. Under normal circumstances, insulin facilitates the uptake of glucose into the cell, providing energy and maintains the blood glucose level. But in insulin resistance, this process is impaired, leading to elevated blood glucose level. The pancreas compensates it by producing more insulin, resulting in hyperinsulinemia. And if this is not controlled, the risk of having type 2 diabetes increases, and eventually you get it. So while dealing with high blood pressure and diabetes in emergency room, it is, I would say, a silent disruptor. Because let's start with these both diseases. We often tend to see patients which have high blood pressure that is above 180 systolic and 120 diastolic, and full blown diabetes that is HbA1c more than 8. They are significantly at higher risk of having heart attack, strokes, and organ failure. Now, how this insulin resistance makes this thing worse? Because when patient is having hypertensive crisis and stroke, what mechanism that provokes this is insulin resistance damages these vessels and making them stiff, and they are eventually becomes unresponsive to the medicines that we give to prevent these conditions, though this will lead to poor blood pressure regulation, clot formation, and higher stroke risk. In heart attack and cardiac arrest, insulin resistance and inflammation and the oxidative stress, this will result into heart attack, and it will eventually lead to poor recovery. So uh, for this was the mechanism and etiological part, but now I'll discuss is the difficult blood pressure control. What happens in insulin resistance is we start off some of the medication to lower their blood pressure in ER, that is emergency room. But the standard blood pressure medication are like AC inhibitors and beta blockers. They will won't work effectively in this insulin resistance patient. So eventually, what happens is these hypertensive and diabetic patients in ER, we are not just treating their numbers. We are fighting against a metabolic disorder that is actively damaging their blood vessels and cardiovascular system per se.
All right. I think you have covered how it complicates the treatment, but I'd like to understand how nutritional deficiencies like vitamin D, vitamin B12, plays an important role when it comes to treatment outcomes. Also, how insulin resistance is related to immune responses as per your experience.
It's my own personal experience about the vitamin A deficiency. It is a truly an epidemic kind of a situation in India, because people are eventually nowadays living in indoors and they are doing corporate jobs. They are not seeing the sun so often, and they are likely to be deficient in vitamin D. Among all of my colleagues, I have been, because I was found severely deficient in vitamin D, so I have advised all of my colleagues and my family members about that I advised them investigation, and they are eventually found out to be vitamin D deficient. So according to me, vitamin deficiency is a very hidden risk factor. It's actually a hidden risk factor in your all your metabolic health. Because what it does is it if you are found deficient, or if you are deficient in vitamin D, it eventually lead to weakened immunity. And there are if you are in ER emergency room with severely deficient vitamin D levels, your chances of getting the infections because of your weakened immunity, like sepsis, pneumonia, and other post-operative infection, the chances of getting that is it will be increased, and it will also lead to increased inflammation, which will eventually fuel the cytokine storms which we have seen in COVID-19 and kind of patient. So for takeaway for the vitamin D part is it's very crucial in maintaining your immunity and your overall metabolic health. And I would like to discuss the significant role of also vitamin B12. It is also very important to consider, because majority of Indian population are vegetarian, and they tend to lack in vitamin B12 level in their bodies. So vitamin B12 is also very much important in terms of maintaining your metabolic health, because it leads the deficiency of vitamin B12 will lead to eventually lead to neurological impairment, and this deficiency can mimic stroke and causes delirium, and it worsens your neuropathies. So patients of vitamin B12 deficiency have higher cardiovascular risks, because of B12 deficiency increases the level of homocysteine, and it raises the chances of patients of getting blood clots, strokes, and heart attacks. And in addition to that, it will lead to anemia and oxygen transport failure. So poor B12 deficiency delays your post-op recovery. Post-op recoveries are, that is you cannot recover after your OTs, whether it is emergency OTs or the elective OTs. There are slight delay in your recovery, and it increases the fatigue also. So many diabetics and elderly ER patients, they are likely to be deficient in B12 and D3. So this vitamin deficiency should be taken care of in, very crucial manner. Yeah. And about immunity, actually, what this vitamin deficiency will lead to is as I said, it leads to immune dysfunction. But this deficiency, how does it affect the our defense mechanism? There are neutrophils. They damages the neutrophils because they are the body's first line defense of mechanism. So they become sluggish. So they becoming sluggish will make the infection like pneumonia and sepsis harder to fight off. And macrophage and T cell also don't function properly, leading to higher ICU mortality and septic patients. And the chronic low-grade inflammation make the body overreact to the already existing infection, and it will increase the cytokine storms that we have seen in sepsis and COVID-19 patients. So, for us in emergency room, this means that insulin-resistant patients they don't just have any infections; they have infections that are harder to control, they are longer to treat, and they are deadlier than in non-insulin resistance patients.
Okay, doctor, in your experience with regards to anesthetic and surgical managements of patients suffering from metabolic syndrome, how does it impact the surgical outcomes, prognosis, and quality of life post-operatively?
Uh, See, Dr. Neha, what happens in our operation theater is we often see so many patients in so many age groups, but the majority of patients that we found are the comorbidities part that we talk is basically hypertension and diabetes. These are the only comorbidities that I have majority have came across, that people, any patient that walks inside the OT in preoperative evaluation, I find that at least 70 to 80% have blood pressure and diabetes in they are on meds basically. So what my perspective is, whenever you are entering by any chance, if there is an elective surgery or an emergency surgery, I hope you don't suffer any kind of emergency surgeries to all who are listening. But in case if you are facing any, if you need to enter the operation theater, I would if I was at your if I am at your place, I would like my self to be metabolically very healthy, because inside OT what happens is surgery to go under surgery is a very stressful thing for your body as well. It's not just the you are stressed out at mind, but your whole body gets so much of stress throughout the surgery. But the metabolic syndrome and its anesthetic challenges are very different. Metabolic syndrome is basically a cluster of central obesity, hypertension, dyslipidemia, and hyperglycemia. So all of this creates challenge in anesthesia and preoperative care. So it will basically this patient have increased cardiovascular risk. They have higher risks of getting myocardial infarction, strokes, and arrhythmias during the surgery. This is because of the endothelial dysfunction and insulin resistance that reduces the vascular activity and making the intraoperative, the blood pressure monitoring and those management difficult for us. And the respiratory challenges. Basically, metabolic syndrome patients are having obesity, and their metabolic dysfunction will contribute to the obstructive sleep apnea and the restrictive lung diseases that will reduces the capacity of lung to breathe properly. Those patients, they have central obesity, they will be eventually having lesser of the lungs function in comparison to the normal BMI person. So will this factor will increases the risk of airway management. For us, an anesthetist, airway management is very crucial, and it will lead to difficulty. And during and performing or inducing the patient and during giving them anesthesia, it will lead to hypoxemia and the postoperative lung complications like pneumonia and respiratory failure. And the one more important part is wound healing and infection risk. So hyperglycemia and microvascular dysfunction will impair the collagen synthesis and immune responses. So this will lead to delayed wound healing and higher rates of surgical site infection, and it will eventually can be converted to sepsis. So wound healing and infection risk also is there. and the impact on surgical outcome and their prognosis. These patients will likely to be having higher mortality and morbidity because metabolic syndrome increases the postoperative cardiovascular event and infection. So they are tend to stay in hospital more. So their hospital stay is more prolonged the compared to the normal person. So, like example, if I would say that in total knee arthroplasty, if you are going under total knee arthroplasty, studies have shown that metabolic syndrome patients have poor functional outcomes and they have increased joint inflammation and the slower recovery compared to the non-metabolic metabolic syndrome patients. So, optimizing the perioperative management that we do inside the OT is very important in metabolic syndrome. So, preoperative optimization is like before the surgery we ask history about the patient's medication and everything is managed beforehand. Though intra-op we are managing it, but beforehand, also before the surgery, we are going to, manage everything uh, in detail. Everything should be in control. Though we are doing it with the medications, but it need to be under the normal range. So the second part is the tailored anesthetic approach that I am like it's very long thing, but I will try to summarize it as good as possible. The regional anesthesia technique that we give is the anesthetizing the part that is required only. If the part of matlab if the operation is performing on this area only, so we'll block this area only, right? That kind of a operative anesthetic approach should be required. So careful intraoperative glucose control and this kind of other things should be look out for, and the multidisciplinary collaboration. So all team from the starting from the endocrinologist, cardiologist, nephrologist and nutritionist help to prevent this perioperative metabolic optimization. Yes, so to conclude it, metabolic syndrome presents a real challenge in perioperative medicine. It increases the surgical risk and complicates the anesthesia, and it prolongs the recovery. But with early identification, meticulous perioperative planning, and a team based approach, we can significantly improve the surgical outcomes and long term patient health. As anesthesiologist and perioperative physician, I have a critical role to play in this process because managing metabolic X syndrome isn't just about diabetes prevention, it is about saving lives in the operating.
Thank you, Dr. Maunil, for explaining that bit. I'd like to ask Sandesh if he has certain questions for you.
Right. I have a question on liver health / liver injury, Dr. Monil. Can you speak to us a little bit
Hello?
about the complications, liver injuries like extreme NAFLD, fibrosis, NASH brings in acute emergency care? How does it make your life difficult?
So see, this NAFLD part is very much of a acute emergency kind of a situation because whenever your liver is damaged up to an extent, see the starting of fatty liver grade 1 2 3 is a normal situation. You can walk around and having a fatty liver, but when it progresses to the fibrosis and eventually full blown cirrhosis and liver failure, it will create so many complications. I will enumerate that one by one. First off, one of them is ascites. That is, the liver fibrosis will lead to portal hypertension. Portal hypertension is your vessels inside the liver will constrict and it will lead to the portal hypertension. And eventually, those fluid that is flowing around inside the liver will, due to the fibrosis, it will eventually accumulated in your abdominal area, and that will lead to the ascites. So clinically, this patient will present with abdominal distension and discomfort, and in emergency setting, significant ascites will raise and compromise the respiratory function, and they will may necessitate to paracentesis to alleviate this respiratory breathing symptoms. The second one is hepatic encephalopathy. The impaired liver function associated with fibrosis will lead to accumulation of neurotoxins, notably ammonia, that is eventually to be excreted by the liver, but it will accumulate since our liver is in failure. It will accumulate and will culminate in the hepatic metabolic encephalopathy. So basically, patient have a spectrum of symptom starting from subtle cognitive changes to profound coma. These are the spectrum of the symptoms that patient may suffer. And the prompt recognition and management of these symptoms are very essential to prevent the irreversible neurological damage. So we need to act upon it very early in the stage of this developing these symptoms. And the third one is variceal hemorrhage. So the back pressure changes that I talked and will that results into the ascites, same will happen with the variceal hemorrhage, that the lower part of the esophagus, the blood vessel they are supplying the lower part of esophagus will eventually dilate due to back pressure changes, and they have there is development of varices, particularly in the lower part of esophagus and stomach. So these varices are very prone to rupture. They have very weakened, thinned out wall because of the pressure changes, and they are taking time bomb. They can rupture anytime. So they are very prone to rupture and leading to massive gastrointestinal bleeding. So it is a kind of a die-hard emergency, and we need to intervene immediately to stop that. So we do banding. So gastroenterologists basically perform those banding, and we are there to give anesthesia to patients, and it's a very critical situation when you are anesthetizing this kind of patient, because any time those time bomb can rupture and the enormous amount of blood will eventually come down to through your stomach esophagus to your respiratory tract, and once it goes inside the respiratory tract your lungs are totally damaged. So it's a very critical situation, and I would say that it's better to prevent uh, this situation before it's too late. I would just say this one line, that it's better to prevent it, because inside the operating room and seeing this patient in emergency care, it's very, very, very disheartening to see those patients suffer. And I hope whoever is listening to these lectures and all the metabolic health conferences topics, they need to get that thing in mind, that there is no good way to manage your body, and it's just not good at the other side of the you know hospital door. It's very messy. You will just be found in loop of every other diseases that will come freely with diabetes and hypertension and other metabolic x situation. And the other thing which you will be having with liver injuries, coagulopathy, your blood that there is supposed to clot once you get a cut won't cut, and eventually you will bleed to death if there is some mishap in your circulatory system. So yes, it's very, very, very critical.
Thank you, Dr. Monil. I actually had no idea about what happens, in the critical room and the role that metabolic health plays. Right? As a coach, it just adds more humility in my role, I guess, as a coach.
Exactly.
I do have one follow-up question on the B12 part that you mentioned. We know that as a country, India is severely vitamin B12 deficient. Uh,
Yes.
any thoughts on how you go about when someone suddenly lands up in the emergency medicine room with a very low B12? What things you have to do? Because as a nutritionist, what I know is you cannot rise it too fast unless it is an IV. So what do you do in a practical situation like that? Because you said B12 is so important.
See, Mr. Sandesh, B12, basically, we haven't came across that deficiency that people are not presenting to the ER because of the vitamin B12 deficiency part. They will present to the ER with some other symptoms, which we cannot, target it out to the B12 deficiency, because like this specific thing is because of B12 deficiency. But let's say that the deficiency is a neurological, that will lead to neurological impairment, and that deficiency can mimic, I would say, can mimic stroke and causes delirium. And sometimes what happens is they'll have extreme neuropathy, like they have sudden shooting pain of the backside of their leg, and they'll present with it. You cannot just point it out that's because of this, because there are differentials. Like it's a traditional medical practice that will follow the differential diagnosis of this. So eventually, when we send investigations, and eventually, after investigation comes, then we find out that this patient is actually having the symptoms because of B12 deficiency. So acutely they do not present in B12 deficiency, though I have found one patient of vitamin D deficient severely presenting in ER. Yes, that's all I have in experience of mine pertaining to vitamin deficiencies. Yes.
Thank you, Dr. Maunil. This was very insightful for sharing some of the unique experiences you had. You shared with us some practical issues you have faced in the emergency care when dealing with
Yes.
patients and having insulin resistance. Any final word you have before I call Shashi and Anup back here?
See, the final word I would say is maintain and prevent your health as much as possible. As much as possible. Hello?
Go ahead, doctor.
Yes. I would say maintain your metabolic health so beautifully that you should not land to emergency room so often, and maintain your level of diabetes and hypertension. Matlab, you should be aware of your metabolic health so that you should not get diabetic hypertension unless you are type 1 diabetic. That's because you get it from your even earlier years. But the type 2 diabetic and certain other metabolic X comorbidities, you should be aware of them and you should not get it. Otherwise, on the other side of the operation theater or the hospital gates, there is very a critical scenario that will eventually will make you accustomed to those drugs, and it's very difficult to maintain as you grow older to cope up with those medications.
Yeah,
It's very
thank you. That was very insightful. Thank you so much for your time, Shashi.
Thank you.
Anup, over to you.
Yeah,
Dr.
congratulations.
Yeah.
Shashi,
Anup,
start. Yeah, start.
Okay, Dr. Maunil, thank you very much for sharing your insight, and I think it's very, very critical because you work in an emergency setup, and
Yes.
whatever you say, we also in coaches in our own practice we also see very severe deficiencies of D and B12. Practically everyone who comes to us are deficient B12 and D unless
Yes.
they keep supplementing.
Unless, yes. I have that thing in my mind that who is having vitamin D more than 50? Matlab, he is superhuman. According to me, without supplement, if he's maintaining more than 50, then he's a superhuman. In
No, they
Indian.
have to be deficient. So I
Yes.
think your job becomes even more critical because you can prevent the future
Yes.
complications as you identify this, and
Yes.
possibly also explore the option in future of measuring insulin resistance in those who are admitted if it is easy and is permissible. Otherwise,
Easily.
okay.
Exactly. I have this you have told me, but I have talked with my professor who is a departmental HOD. But in our setup, it's likely not possible because it's a semi-government setup. So getting an insulin measurement would be a very difficult. So yes, getting lipid profile, we will get it in 1 or 2 days of span. We cannot get it like that. So it's very difficult right now. But I hope that this goes well.
Thank you. Anup.
Thank you, Mr.
Yeah, congratulations, Dr. Maunil, on few counts.
Thank
Count
you.
number one in 30 minutes. I think you covered about 60 minutes of content, right?
Thank you so much.
And and we are very proud, to see a mainstream doctor and a D-Life certified low carb nutrition and metabolic health coach making his
Thank
debut
you.
in an international conference. So all I can
All
say
credit
is
to you.
go ahead and conquer the world. Good
Thank
luck.
you. Thank you so much, Mr.
Thank
Anu.
you.
Means a lot. Thank you. Thank you.